Thank you. It's a real honour to be here and on this panel and discussion. And I was tasked with talking about patient-specific alignment, starting with the concept that no two knees are the same. So before I start, just look to your left and look to your right. And do the people on either side of you look exactly the same? I'd be surprised if they do, and their knees are not going to look exactly the same. They're all different. I was trained that these are all varus-aligned medial compartment osteoarthritic knees. Approach them exactly the same way. They're not the same, and we'll come back to why. If we have a look at some of the data around it, this is a study from Coventry looking at North American knees. There's a similar one from Canadian knees. If they're all the same, there'd be one dot on that plot, or a pretty tight plot, but it's a very spread out plot. This landmark paper by Bellemans et al. In 2011 looked at young Belgian knees and saw great variation in coronal alignment, axial alignment, and sagittal alignment. These are some of our knees from a database we've got of over 1,300 knees pre and post knee replacement. If you look at the femoral coronal angle, there's a range of 21 degrees in that data set. In the tibial angle, a range of 25. In the rotationary angle, a range of 11. If we look in the literature at what you would call normal anatomy, there's a set of ranges that we all assume these are normal knees. Well, if we go back to our data set, 16% in both the axial and coronal planes were outside that range. They're abnormal knees. Over 50% had at least one deformity, and nearly 1 in 8 had 2 or more deformities. So there's enormous anatomical variation in the population. That's easy to prove. So now we're starting to phenotype them into groups, combinations. And the one we're all looking at the moment is this from one of our great friends in Sydney, Sam McDessie. The classification of knee alignment based on 2 measurements. One's the lateral distal femoral angle and one's the medial proximal tibial angle. And you measure 3 things in the CPAC. The mechanical alignment, the constitutional arithmetic alignment, and the joint line obliquity. And they're independent. The mechanical hip-knee angle is the constitutional alignment of the limb, the bone and the cartilage. It's dependent on both the constitutional anatomy and the degree of arthritis. So as osteoarthritis progresses and the cartilage erodes, the mechanical hip-knee angle will change based upon the degree and location of that cartilage wear. The arithmetic hip-knee angle, though, is the constitutional alignment of the bones of the limb, the femur and the tibia. It is independent of the cartilage and thus the degree of arthritis. As osteoarthritis progresses, the cartilage will erode, the mechanical alignment will change, but the arithmetic is unchanged until you get to the point where there's bone loss. So that's why you're able to predict what the knee was like when it was healthy. By dividing them up into 3 groups based on 1 standard deviation, you have the neutral ones, you have the varus limbs, and you have the valgus limbs. Joint line obliquity is an independent variable. It's the plane created by the articulation between the femur and the tibia. In extension, it's the sum of the MPTA and LDFA. In flexion, it's the sum of the PCA and the MPTA. It's described by the direction of the apex of the angle, so distal or proximal, depending upon its extension into the midline. And again, divided by 1 standard deviation, we can have 3 groups: neutral, apex distal, and apex proximal. It is independent of the mechanical axis. Based on that, you end up with 9 knee phenotypes. So then let's see how they are distributed amongst the population. In Bellemans' cohort and in our range of osteoarthritic knees, about 65% were covered by type 1, 2, and 5, but that leaves a third of knees outside that range. If we see how many knees are naturally mechanically aligned, it's 15%. So anytime you're putting in a mechanically aligned knee replacement, 1 in 8 patients is going to have the alignment they started with. The rest, you are changing their alignment. So with all these knees that look exactly the same, they're all actually completely different and need to be approached that way. If we look at distribution around the world, the CPAC type 1 in Australia is about 20%. In India, it's 58%, with variation across populations. You can approach these as the same. And the closer you look, the more different you see. The CPAC's only in 1 plane. It's a coronal alignment. The knee doesn't function in 1 plane. Let's look in the sagittal alignment. Let's look in the axial alignment. And the closer we look, the more variability we're going to see, not less. And our tools are improving. We started with x-rays. Now we've got CTs, MRs, and robots, so we can see closer. These are both in 4 degrees of varus, but they've got wildly different rotation. You approach those knees the same way, they are not going to behave the same way. So you need to individualize your approach. So we've got 2 ends of a spectrum here. Fixed implant positioning, where the implant's positioned due to the surgeon philosophy and the soft tissues are released to accommodate that position. Or you can prioritize restoration of the alignment and native soft tissues and accept some off-axis implants. So you've got strict mechanical alignment, 90-90 with 3 degrees of rotation at one end, and you've got pure unrestricted resurfacing, where you're trying to reproduce the cut plane in all 3 planes with no limits. Then you've got a spectrum in between. Hungerford described in 1982 the anatomic alignment. Instead of cutting at 90-90, bit of 3 degrees valgus on the femur, 3 degrees varus on the tibia. That was closer to the averages of the anatomy, but it's not normal. Then you've got restricted KA. This is where you are happy to go off axis, but with limits. How far off limits differs from surgeon to surgeon and gives you some idea of where you'll end up. If we think about this approach for a minute, if we think about the ability to restore patients' native anatomy, it's 100% if you're happy to go to any axis with unrestricted KA. It's 15%. 15% of patients are CPAC 5, that's a mechanically aligned knee. So 85%, you're changing their alignment. The need for soft tissue release should be a minimum unrestricted KA through to a maximum the further you're changing it. But the potential for extreme implant alignment, 0 if you're just always going 90-90, and it's a maximum if you're going to cover the joint surface in all 3 planes. So when I'm doing my knee replacement, I'm balancing 4 factors. The desire to restore 3D constitutional alignment, how acceptable I can go off axis, preservation of soft tissue, and balance. And I prioritise them in this. Arthroplasty is a game of compromise. I've got my limits where I'm going to put the alignment. I want to release only when balance can't be achieved with bony cuts, and a primary goal is perfect balance, either manually assessed or with a Verisense. It's a bit like a properly fitted suit, a bespoke suit for the patient versus one that you jam the patient into. They feel more comfortable. So how does that work for me? So in 2019, I looked at my mechanically aligned cohort versus my restricted KA with 200 knees, about half in each. I did all the cases, single implant, computer nav with robotic assistance. The femurs were in a little more valgus, the tibias were in a little more varus. Interestingly, to achieve full extension, you could do it with a KA knee with 12% less bony resection. Overall alignment was slightly varus, but if we look at the degree that we're within 3 degrees of neutral, there were no difference in outliers, so we're not getting extreme alignments. This is the slide I think most important. Any releases, 72% of my mechanically aligned knees needed a release versus 3.3% in the KA group. So a drastic release of soft tissue intervention. So with those off-axis alignment, we get less bony resection, less soft tissue release, and good extension. The last thing we published this recently, looking at just over 500 knees with 2 different robotic systems, using that philosophy of restricted KA with a minimum of 1 year follow-up. We saw slight differences between the different delivery tools and the implant position, but no different in outliers. The release rate in this group for a major release was less than 1%. We had 13% of minor releases, mainly pie crust on the medial side, where I just didn't want to put it in quite as much varus as the patient wanted. Outcomes were good. We had Oxford knee scores of 43 with one system and 42 with the other at a minimum of 12 months and no difference in VR12 scores. Excellent Q scores with just a slight difference in symptoms, and the same for a PASS score in the Mako group because they were a little longer in their follow-up. So in conclusion, people do not look the same. Their knees are not the same. If we look at how many of them are truly mechanically aligned knees, it's 15%. We're going to balance multiple factors when we're doing that knee replacement to create a personalised alignment strategy, and where you sit should be somewhere on that spectrum. I sit a fair way up towards the kinematic end, but not unrestricted. There are limits because I agree with the concerns about longevity. I've had no revisions in that group and good outcome scores. Thank you very much.